Welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is August 4, 2021. This episode was recorded on June 14, 2021. I'm Jeff Lassers, and I'll be your host. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. Today we welcome Dr. Christopher Richards. Dr. Richards is an emergency medicine and EMS physician in the Division of EMS in the Department of Emergency Medicine at the University of Cincinnati, as well as a member of the UC Stroke team. He is the EMS medical director of several EMS agencies in Southwest Ohio, as well as the UC Health Mobile Stroke Unit. He collaborates nationally as a committee chair of the Prehospital Guidelines Consortium, an advisory board member of the American Stroke Association, and as a representative to the National Institute of Neurological Disorders and Stroke Brain Attack Coalition. Dr. Richards is here to provide us with his perspective regarding the development of stroke systems of care in the urban environment. Doc is an ED physician with a deep background in a variety of EMS systems. Most recently, Dr. Richards was a co-author of the 2021 Recommendations for Regional Stroke Destination Plans in Rural, Suburban, and Urban Communities, which is the focus of today's discussion. This landmark consensus provides local and regional EMS agencies and stroke advisory committees with guiding principles and recommendations for how to integrate the elements of a stroke system of care in three key regional settings: urban, suburban, and rural. It also takes into account the different resources, hospital certifications, geography, and population density. Additionally, it seeks to inform or update EMS about new models and systems of acute ischemic stroke care. You can find a link to the 2021 Recommendations for Regional Stroke Destination Plans in Rural, Suburban, and Urban Communities in the episode description. To maximize the power of the recommendations, the American Heart Association, American Stroke Association produced a very cool and very useful website full of resources and information directly related to helping EMS develop and or fortify their stroke systems of care. I highly recommend you visit www.stroke.org/stroke transport plans and use it to consider evolving the stroke system of care in your community. This is a fantastic resource for anyone with any interest or stake in their stroke system of care. This is an especially helpful website if your EMS system is considering implementing a stroke severity scale, or if you're considering hospital bypass criteria for patients with LVO strokes. During this episode, Dr. Richards will help us appreciate what is at stake for stroke patients. From there, we'll get into the meat of the discussion, which is a focus on the nuances, advantages, and disadvantages of the urban environment regarding EMS and stroke. Finally, Doc will give his recommendations regarding how EMS systems should use the contents of the consensus paper to improve their stroke systems of care and strengthen their stroke chain of survival. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review. It really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Enjoy the show. Good afternoon, Dr. Richards. How are you?
I'm doing well. Thanks for having me.
Thank you for joining us. Can you please kick us off by letting everybody know who you are, what you do, and where you do it?
I am an emergency and EMS physician at the University of Cincinnati in the Division of EMS, Department of Emergency Medicine. I am also a member of the UC Stroke team as well. In that role, I am EMS medical director for a couple EMS agencies here in Southwest Ohio: Westchester Township, Hamilton Township, Deerfield Township. I'm also the medical director for the UC Mobile Stroke Unit. Before coming here to Cincinnati, I was in Chicago, did residency at Northwestern. After residency, did my EMS fellowship, but I also did a health services research fellowship and a stroke research fellowship through StrokeNet, which is kind of a national research network for stroke research.
Can you let our audience know what a fellowship is? Give a little context to those EMS providers that are either new to EMS or unfamiliar with what that means that engage EMS and physicians.
Yeah, absolutely. So residency is kind of that core training in emergency medicine. And then beyond that, some physicians and actually pharmacists and across the board, some of your nurse practitioners, PAs, do specialized advanced training in a very specific area. So for us who are EMS physicians, we do a year, potentially even two, learning about EMS systems, out of hospital care, work in that environment. And then for kind of the research side of things, I ended up getting a master's degree and did focus dedicated time specifically around health services research. So thinking about systems of care and the research on how to best study and then also improve systems of care.
That's super cool. So you actually have more of a well-rounded view of not only EMS, but what happens in the ED, but also looking at it from more of a trained perspective of how do you put all these together into one big influential sphere that all has to work in harmony together to serve this really diverse population, which are humans.
And you know what, Jeff, at the end of the day, that's really what matters is the patient that we're taking care of in front of us.
Cool. So let's talk about specific patients, stroke patients. Can you help us appreciate what is at stake for stroke patients?
For hopefully all of our listeners, but if not, you have taken care of, or at least envision yourself taking care of a potential patient with acute stroke. But for those of you and us who have been in emergency care for a while, we've also taken care of patients who have had strokes much further out. And we've potentially seen the long-term consequences of stroke, potentially untreated or potentially treated and still has some functional limitations. And so when we think about acute stroke treatment, in that acute phase, there are some potential therapeutic options that can be administered at the hospital to potentially reverse some of the effects of a stroke. At the end of the day, hopefully improve long-term outcomes. That's where thrombolysis with medications like alteplase or tenecteplase come into play, minor surgical procedures, endovascular therapy to remove clots for large vessel occlusions. And then additionally for hemorrhagic type strokes, which are less common, but certainly ones that we see in the pre-hospital setting, any kind of therapeutic options for hemorrhagic stroke as well.
So there's virtually everything is at stake for these stroke patients, right? And only the technology is getting better to help them improve that. So as we build with our EMS systems and we think about these systems of care, there's nuances for every specific environment, specifically the urban environment. What is your history with the urban environment and setting up a stroke system of care and considering all those little different nuances you have to really worry about in that specific environment or set of conditions?
Bringing kind of the concept of that treatment for especially acute ischemic stroke, because that's usually what we talk about in this setting, it kind of boils down to the concept that minutes really do matter. So having a thrombolytic medication on board or getting the endovascular therapy in place sooner rather than later really does translate to improved outcomes. And so that might mean improved functional outcomes. That might mean less chance of being discharged to a higher level of outpatient care, like a nursing home or a long-term care facility. Maybe that means that the patient ends up going home. There's also mortality benefit in some of these situations as well. And so when these therapies are given in a time-sensitive way, those improved outcomes can be maximized. The flip side of this, too, is that some of the complications that sometimes are a part of this, of reperfusion therapy, are decreased when patients receive them more quickly. So when we think about developing a stroke system of care and trying to construct a care delivery system around the concept of having patients with suspected stroke be evaluated in a timely manner so that diagnosis can be made sooner, so that therapy can be administered sooner, we are thinking about those long-term outcomes. My prior experience back after residency and fellowship was as an emergency and EMS physician in Chicago, where I was for a great number of years, working with the EMS systems and our hospital partners there. I was there in 2015 when studies came out that showed that endovascular therapy really made a significant difference in patients with large vessel occlusion. So we could actually see the blood clot on CT angiography. So IV contrasted CT studies that made that diagnosis go in, minimally invasive procedure, take the clot out, reperfuse, and reestablish the blood flow. It was 2015 when those studies really showed a significant signal. And so I, along with a number of our partners in Chicago, really spearheaded our effort to look at our system of care and think about how we can maximize the opportunity for timely treatment for patients with suspected large vessel occlusion and other types of severe stroke. When we're thinking about especially the urban environment when treating stroke, there are actually a lot of advantages that a big, bustling urban environment has. First off, actually, the likelihood of having multiple stroke centers is pretty high. To have kind of one hospital stroke center in town, especially in a big urban environment, is far less common than having really an abundance of resources, which is in some respects a really good thing. You have a lot of resources and allocated potential opportunities for ultimately the patient, but also our EMS providers when thinking about destination decisions. Ideally, when stroke centers are in abundance, that could also transport to shorter transport times, certainly shorter than looking at a more rural environment. Typically, there are resources available to urban EMS practitioners like online medical direction at potentially stroke centers where paramedics, EMTs can call in and talk to a provider who works at a stroke center. And those hospitals may be able to actually provide some of the diagnostic and potentially even therapeutic options that maybe a less resourced, more rural environment may not be able to offer. For example, well, let me put it this way. So the FDA indication for alteplase, which is a clot-busting medication used in thrombolysis, is up to 3 hours. Guidelines would say that administration up to 4 hours is generally reasonable and recommended. There are additional research studies that have looked at patients who wake up with stroke symptoms, where we don't know where their last known normal time was exactly. And so we have to go back to essentially when they woke up from sleep. Usually that puts them outside those time limits. However, doing specific MRI protocols right there after the patients are brought to the emergency department after they get their non-contrast head CT can potentially expand out the window for safe administration of thrombolytic medications. But that has to be done in a place that can do MRIs 24 hours, which are more likely to be seen in urban centers. And then the last potential advantage of that urban environment is the emerging technology of the mobile stroke unit. That is kind of a new and emerging asset in some areas, and integrating those certainly has some advantages, has some logistic operational challenges as well. But those are things that we'll see emerging in the urban environment, more so than in the rural environment.
So a couple follow-up questions on those advantages. Number one, there being more stroke centers, more than likely, there will be more stroke centers per capita in an urban environment than there would be in, let's say, a rural environment. Is there better patient outcomes when you have a higher population of stroke centers than there are in places that only have, let's say, one stroke center within 3 counties?
It's a great question, and it really kind of translates into what are potential resources available for the patients cared for in that system of care, right? And so generally when you have a lot of resources available, that should translate into timely evaluation times, timely transport times, which is correlated. Now, an important part, and actually the consensus statement gets into this, which is reporting of time metrics and of data in a way that really helps to improve the overall system. The point you bring up is important, especially for those involved in the stroke system of care, to kind of understand where the assets in the system of care are providing to their patients. And we'd like to see timely treatments and good outcomes, and we'd like to see kind of the extension of that. However, that transparency is an important part of that, which locally is an important consideration.
So it sounds like the availability of more resources lends itself to potential being greater, but it depends on all of those relationships of all of the stakeholders working in harmony to produce that outcome. So the presence of the resources doesn't necessarily correlate to better patient outcomes, rather than how those resources all work together in the interest of the patient.
I think that's a really good summary, is really that coordination. The potential advantages and resources that the urban center has are important to recognize, but to have a highly functional, timely delivery of care system, even in a rural setting, is certainly possible. It just takes the coordination of the potential resources and assets that are available in those specific systems as well.
So the advantage of the mobile stroke units are those, I don't want to get too much into mobile stroke units because they are so rare, but that doesn't make them less interesting because they are certainly interesting. They sound really expensive. I'm just going to put that out there. And I'm sure that kind of is prohibitive in a way. But if we could touch on this mobile stroke units, I'm sure there's people out there listening that love the concept of this. So can you touch on why is that such an advantage as an emerging technology right now?
I'll try to keep it brief, but essentially a mobile stroke unit, sometimes the way I kind of phrase it is essentially it's an acute stroke ready hospital on wheels. And so it's an ambulance with this CAT scan with some sort of thrombolysis medication, and then usually some other advanced medications, potentially to treat hemorrhagic stroke, that are brought actually to the patient's curbside where a diagnosis can be made, either an in-person or telemedicine evaluation by a stroke specialist, and then potentially give thrombolytic medication right there. And so if you're kind of thinking about a stroke chain of survival where it starts with layperson recognition, 911, EMS on scene care, transport, ED evaluation, it kind of compresses the entire time from even the 911 call through the delivery of the medication in a very compressed space. That, again, if we're thinking about minutes mattering for overall outcomes, it really has the potential to improve the timely delivery. And now we're starting to get a signal that it could improve overall patient outcomes as well.
Before we move on from those mobile stroke units, is there anywhere that we can send people to find more information on that if they are interested?
An international organization, probably going to be the best resource, is Presto, Presto. They have a really nice website, and they kind of have some tabs about what a mobile stroke unit is and where mobile stroke units are and some additional information.
Super cool. Maybe we can do an episode with them or on them in the near future with you.
More than happy to.
So working in the urban environment, lots of resources. The urban environment doesn't just bring into these tangible resources, it also brings in human resources. We find that in many urban environments, we get these great training grounds because more people living in a certain area, more ailments for people to practice their medical skills on. That's fantastic. But, we've always heard more money, more problems, and more assets, more problems sometimes. When there's a lot of cooks in the kitchen, you can think of 1,000 different parables to kind of relate here. But talk to us about some of those challenges that present themselves in the urban environment with the context of we're trying to build and or fortify a stroke system of care.
You're right. And so obviously that's just the flip side of the coin, is that while there are a lot of really neat things going on in an urban center, those challenges do exist. And so the first is that while having lots of stroke centers can be a really great resource, that can sometimes put EMS in the middle of a lot of good resources. Sometimes making those decisions can be challenging. Ultimately, we like to kind of think about the right patient at the right time and the right place. And that's a mantra of what we think about in EMS. And ultimately, thinking about what is the best appropriate hospital for these patients is really important. That has implications for our EMS providers, has implications for the hospitals. We talked a little bit about this in the consensus paper, but to bring every single patient to the highest level of care, who may even potentially be having a stroke, may not be the best thing, ultimately. Comprehensive stroke centers, the highest level of care, can really kind of be inundated, whereas primary stroke centers may not see the volume. And this kind of comes back to an overall kind of just concept when it comes to regionalization of care and systems of care, is that they're designed to be able to provide on a regional and a systems level the type of care provided, which does not mean that every single hospital has to or really should provide every single extensive therapy. It really is meant to be kind of done in a coordinated fashion regionally, so we're able to offer the interventions and therapeutics that are shown to improve outcomes for patients. So that's all a long way to say is that when we're thinking about a system with a lot of potential stroke center resources, thinking about how do we make the destination decisions to primary stroke centers, thrombectomy capable, comprehensive stroke centers should be really done with the patient in mind, rather than what could otherwise be other considerations. We talk about how in urban environments, often that brings multiple health systems in play. And that can cause confusion and sometimes consternation for our EMS practitioners who are really looking for a clear answer. And this is where, rather than on a case-by-case and a patient-by-patient basis, having these discussions in consortium models where we have stakeholders that have sat down and thought about what is the best system of care we can provide to a patient is really an important approach that, especially in the urban environment, but really in any environment, can be done to help support the overall care of those patients. There are some additional challenges, of course, right? And so while there are lots of patients, that also means that there's lots of EMS practitioners. Chicago, we had over 5,000 EMTs and paramedics. And so that translates to a lot of training. The Chicago EMS system does a ton of training to try to keep the skills of the EMS practitioners really sharp for acute stroke patients. But the flip side of that, too, is that while we could do hours and hours and hours of education on stroke, that's only like 1.5% of all the patients we see, right? So we have to think about our asthma patients, our sepsis patients, our trauma patients. And so that is a lot of a balance and a push and a pull. We kind of started to think about a more and more complex system in place that has to translate over to both education and implementation. And then, of course, in the urban environment, it's not just the square mileage, it is the traffic, it is the vertical environment. And so thinking about, a 20-story a condo complex that maybe the elevator is out that day and you have to do the stair chair down, flights, that adds to transport time. And that has really unique considerations for our EMS practitioners in that environment.
Yeah, Dr. Ethan Brandler, who we've had on the show from New York City, he talks about the vertical time. I show up on scene to our max 4-story buildings in my township. We have one that's 5 stories, but you get the idea here. If the elevator goes out, my vertical time is not that challenging. You go where he's at, 80, 100 stories? This does not sound like a fun idea, but that scene delay to the patient, that gets real in that vertical time and should be considered for a patient when time is tissue. That's incredible.
Ethan and I have also talked about the traffic considerations in New York City as well. And, especially if you're kind of thinking about, well, how does the urban and rural recommendations translate to my system? Well, if you have a 45-minute transport time, even if it's 1.5 miles, well, then we're starting to kind of think about how do we really translate the recommendations here?
Yeah, busy is relative, right? Because a busy road where we're at, and it's a fairly congested area, 45 minutes, I'll get you 2 to 3 different counties in any direction. But where you're at 45 minutes, you might be better off putting them on your back and walking them down the road. You know what you need? There you go. Sherpas, EMS Sherpas with the rickshaws. Low lights on the that actually might win in some circumstances to the hospital. So anyway.
I actually have a photo that one of my colleagues sent me. This is a number of years ago in Chicago, where it was in front of our emergency department, one of those bicycle taxi things where someone showed up in that manner. It was pretty impressive, but potentially the fastest way.
It's safe. And if you got there, point A to point B, thinking outside of the box.
There you go. So another important consideration in thinking about the right destination for our stroke patients is really to look at the entire range of assets that a stroke system has in place. So primary stroke centers serve a critically important role, even in a busy urban environment. Primary stroke centers are ones that generally give thrombolysis medications and admit stroke patients. Comprehensive stroke centers can offer the endovascular therapy for large vessel occlusion, hemorrhagic stroke as well. Thrombectomy stroke centers are kind of right in the middle, where they give thrombolysis and they do endovascular therapy. Their accreditation is less for hemorrhagic strokes in those situations. So thinking about acute stroke patients, while a patient receiving thrombolysis medication is really potentially served at any of those type of stroke centers, those with the more severe stroke syndromes, those with the large vessel occlusion or the hemorrhagic strokes, are really best evaluated and treated at the comprehensive stroke center. So when we're thinking about patients that present through EMS for evaluation, it is entirely possible that a patient who receives thrombolysis may not have a large vessel occlusion, may not be a candidate for endovascular therapy, is a very appropriate patient to have at a primary stroke center. And that's important for the primary stroke center. It's important for them to have the stroke volume at primary stroke centers where they can continue to provide the excellent care that they provide. Similarly, for comprehensive stroke centers, if every single stroke patient went to the comprehensive stroke center, they'd be busting at the seams. They couldn't provide that regionalized care that we look for in the comprehensive stroke center, the thrombectomy capable stroke center. And so that's kind of taking a step back when you think about regionalization of care and systems of care, having assets available to the community and patients therein, but at designated centers is kind of the crux and the concept behind regionalization systems of care. And that's where we as EMS providers come in to think about how do we best think about those destination decisions for patients who might benefit from that higher level of care. We think about that a lot in trauma, right? And so if we have a hypotensive patient who is in a motor vehicle collision, well, we should have them go to the highest level of trauma center. If it doesn't meet those criteria and can be stabilized elsewhere, evaluated, potentially transferred on the back end, that's an appropriate utilization of that trauma system of care. You can kind of think about it in some respects in the same way for the stroke system of care.
So obviously the gold standard in that stroke system of care, when you guys are assessing a patient with new onset neurodeficits, is the NIH stroke scale. You're now seeing the emergence of stroke severity scales, which is essentially an NIH stroke scale used by EMS. And there's a million different versions of that. We all know I'm a FastED fan. That's the one I'm using. But do the presence and use of stroke severity scales by EMS make things less or more challenging for that aspect of the urban environment? And what I mean is, are we under or over triaging with the use of stroke severity scales? Is the juice worth the squeeze in the urban environment? That's what I'm getting to.
So to answer the question, if we're under triaging or over triaging, the answer is yes to both. So the advent of the severe stroke scales that a lot of systems have implemented, especially since 2015, is to kind of boil down that NIH stroke scale, which is a huge scale, lots of moving parts. While it has been studied in the pre-hospital setting, it's a little bit of a complex tool. So a lot of the stroke severity screens have just meant to kind of distill it down to really kind of hit the high points to potentially identify patients who might benefit from endovascular therapy. No scale is perfect. Even the NIH stroke scale is not perfect. You can have large vessel occlusion, have an NIH stroke scale of 1. Now, guidelines would say that patients less than an NIH stroke scale of 6, you really kind of have to weigh on a case-by-case basis. And there are ongoing studies to really know if patients with large vessel occlusion and low NIH stroke scales are good endovascular candidates or not, because current guidelines are still greater than an NIH stroke scale of 6, which is a severe stroke. And that's really kind of where the screening tests that we're doing in the field are kind of coming into play. And that's why we're doing them. Now, the question comes down to, and some of the considerations in the consensus paper that we're talking about, you've talked about with Dr. Yalk in a previous podcast, is additional time to go to a center that can do the endovascular therapy basically worth it? And we are still gathering data on this, to be perfectly honest. Right now, from the recommendation papers that are out, the AHA, American Stroke Association, would recommend that patients with severe stroke symptoms, as assessed by the FACEP, the CSTAT, all these stroke scales out there, the recommendations are agnostic to what severe stroke screening tool is used. But whatever is kind of agreed to by the stroke system of care, if a severe stroke is detected, even in the urban environment, to take the additional time to go to a comprehensive stroke center is one of the recommendations. And a lot of that is rooted in, again, the timely delivery of care. So not only is timely thrombolysis associated with good outcomes, timely endovascular is associated with good outcomes too. So even with just a CT angiography showing a large vessel occlusion within 6 hours, those patients generally go straight to the endovascular suite. But even within that 6 hours, the more quickly those patients receive endovascular, get the vessel reopened, they end up doing better. And so to have a direct transport to a comprehensive stroke center that can offer that therapeutic option, at the end of the day, the thought is that endovascular therapy can be done sooner. And we do know this because interfacility transport times can be quite long. Now, I'll take a step back and certainly give a couple caveats. So one is that we're getting some experience out of the Catalan region where RACE was developed. And they, at least in their system of care, didn't necessarily show an improved outcomes going straight to a comprehensive stroke center versus stopping off at a primary stroke center and then secondarily transported. I think we have to kind of learn a little bit more about what that experience was, but also importantly, see what similarities are with that system of care compared to any one stroke system of care where any of your listeners were to practice in. Ultimately, it's a little bit of a trade-off. It's a trade-off between a little bit of an extra transport time to that comprehensive stroke center, potentially delaying thrombolysis for the potential for a more timely endovascular treatment because you're going directly. And this is, again, kind of where feedback from the comprehensive stroke centers and the primary stroke centers and the whole stroke system of care in general kind of comes into play, because knowing how our hospitals are performing in terms of metrics that are set up by external validating and credentialing agencies is important to know when we're thinking about our own local resources, how our hospitals are performing on these time metrics.
So to me, the stroke severity scale use doesn't necessarily lend itself more useful to the urban environment. Again, it depends on how you're using it within your system. So like you said, agnostic to which stroke severity scale. I love that term. That's a very, very polite way of saying, I don't care which one you use, just be good at using it and be really good at communicating those findings to the ED. And the right ED is the one within your system. And that's like a debate a lot of times, because if you've seen one EMS system, if you've seen one healthcare system, you've seen one system, because the number of hospitals and then the number of healthcare systems within that hospital range can definitely have a political impact on how policies or protocols are decided or whatever. It is what it is. But recently, you were a big part of writing this recent consensus paper, which is helping to improve and or fortify stroke systems of care. Can you help everybody understand what this paper is and how it should be used by EMS and their agencies as a resource to really plan for the future?
Jeff, I think you used the right term there, which is it should be used as a resource and as a guide. It is not set in stone. It is not any kind of policy or protocol itself. It is really meant to be a guide based on expert consensus and data that is available, looking at lots of different types of EMS systems. For example, the consensus paper talks about 3 different geographic regions: urban, suburban, rural. Well, it's important to kind of recognize that even if you're, and it uses census level designations, up to 10 types of rurality based on population. And you should know in your region which of these your exact geography is. But the reality is that even if you are in more of a suburban area, but you don't have a hospital for 60 minutes away, well, thinking about kind of the recommendations and context of some of these recommendations in the context maybe more of a rural setting might be more appropriate. It is meant to be a guide. It is also kind of to emphasize some of the important considerations when it comes to timely delivery of therapeutic options, timely diagnosis for the acute stroke patient. And so from at least a perspective of all of the sponsoring organizations, the meat of this paper recognizes that, yes, it's important to offer timely diagnosis, timely treatment. And that might mean a trade-off between going a little bit further to go to a higher level of care. But where exactly that breakpoint is still an open question right now, at least for the urban environment. It does specify a 30-minute transport time to the comprehensive, the higher level of care. But the implications for any given EMS system, stroke system of care, has to be thought of locally. And this is where having stakeholder engagement, having a consortium approach to developing these protocols is so important, because then we are thinking about these considerations, not on a patient by patient. We're there at the curbside. We have lights on. We're trying to decide where these patients go. These decisions are really best taken offline, sitting around a table, having everyone's perspectives considered so that we're not kind of deciding this at 3 a.m. and slinging arrows and stuff because you brought it to this hospital and not that. So, that is where this document comes into play to help inform regional stroke advisory committees on how this is best done. And the other point that I'll kind of emphasize too, in terms of the stroke severity screening that's done, and you brought this up, that nothing's perfect. And so the flip side of this is that there are going to be large vessel occlusions, potentially even amenable to endovascular, brought to a primary stroke center and vice versa. That's okay. We are learning about how to best screen and make these destination decisions as we go along. But it's also important to recognize that the interfacility component of this is so critically important. So especially for your listeners who do interfacility transport, the adage of time is brain is still going when interfacility transports need to happen. And so a safe and efficient transfer of care from a primary to a higher level potentially is critically important. And it's going to happen, like you said, because none of the severe stroke screening is perfect. There's a sensitivity and a specificity balance that has to happen.
Absolutely. That seems to be the theme of everything, the specificity and sensitivity, that balance between the true positives and the false positives, that balance between what did I under or over triage, and then did I take them to the right place? Because the goal is right patient, right hospital at the right time. And that is never, ever challenged. The theme, the intent is never challenged. Now, the logistics are often challenged, debated, and or fought over sometimes agreed upon. Believe it or not, sometimes people come together and they build these beautiful systems that work in harmony across multiple companies, corporations, or nonprofits, however you want to classify those healthcare systems.
Yeah, absolutely. Right. And it's important that everyone's voice is heard in that process. Right. And so even though healthcare, there's a lot of kind of corporate considerations there. Well, there's valid considerations there. And so at least kind of understanding a perspective, hearing those perspectives. But again, not at 3 a.m. at the curbside. That's more when you're kind of developing your system of care and your protocol. The other flip side of this too, Jeff, when you're kind of thinking about screening for severe stroke, is that a lot of the scales, NIH included, really focuses on middle cerebral artery, MCA syndrome. And so that is like your weakness, your speech, but stroke syndromes certainly occur with posterior circulation. So acute vertigo or basilar artery syndromes, which could just be obtundation. And that doesn't even get into hemorrhagic stroke, which could be a focal deficit akin to LVO, or it could just be, again, obtundation, a gaze deviation, a very nonspecific. And the complexities of evaluating those patients go even above and beyond some of the scales that develop. So it's complex. And this is where the ongoing education and discussions around this is so important, because really being there at the curbside, evaluating the patient, getting that sense like something is just not right and their blood pressure is 240. I think maybe we have a conversation with our online and go to the higher level. That's the right thing. That's what we're doing at 3 a.m, that we could never write a protocol.
Yeah, the one thing we got going for us, no matter if you're in the urban, suburban, or rural environment, is that our technology allows us to call people that might know more about us, about that specific ailment. No matter where we are in the whole world, really, you pretty much have the ability to say, hey, you, it's me. I'm dealing with this and I need some advice. The phone a friend.
Phoning a friend is often a good approach when needed.
Yeah, absolutely. So anything more specifically on the urban environment and how this consensus paper can be leveraged to improve a system of care for any system listening right now of any size?
The one last thought that I'll share with the urban environment in terms of potential resource there actually is that there are lots of ongoing clinical research on acute stroke management. Oftentimes those are done at urban centers. And so a potential resource, but certainly consideration or complexity that the urban environment has, are hospitals and stroke centers that are doing research on how to improve overall care. And sometimes those might end up factoring into considerations on how patients are transported, because a lot of the research in the field is potentially expanding safe therapeutic options to patients beyond our traditional contraindications. And so that is only done safely in the context of clinical trials, which are usually done in the urban research institutions. Now, how can we really best serve and use this document to kind of strengthen the stroke chain of survival? Well, it really is important to keep in context that the chain is really only as strong as its weakest link. And so if we really do think about the stroke chain of survival starting at laypersons knowing that a stroke is happening, calling 911 through our EMS and obviously the hospital side, that thinking about public education, awareness and response, messaging, about stroke to laypersons. And to be really honest, it probably goes beyond just knowledge that if I can't move the side of my body, that's a bad thing. A lot of it ends up being interactions with the healthcare system, the emergency care system, prior interactions with 911, language barriers, even in some cultures, kind of a hierarchy of talking to the matriarch or patriarch prior to kind of seeking medical care. These are all really important for undocumented patients, those considerations when police shows up with our ambulances. Those all go into kind of the public messaging and strengthening that first critical anchor of the chain of survival. Next is kind of the interaction with the call taker, 911, emergency medical dispatcher at the PSAB level. We've done some research actually on when laypersons use the word stroke. That's a huge tip-off, perhaps not surprisingly, but a huge tip-off to the call taker to dispatch out as a stroke, which has lots of downstream consequences. We arrive on scene and then subsequently to the emergency department. And so strengthening each link of those changes is important. And then lastly, just having the awareness of how stroke can present. Like we talked about, it's more than just the right-sided deficit with the slurred speech. It might be acute vertigo. It might be severe headache. And keeping yourself armed with the education and the knowledge of how stroke patients can present and what potential options are available to them, even beyond kind of traditional windows and things we usually think about, is really important. Not only now, but in the years to come as the field of stroke really, truly rapidly evolves.
This is usually where the show ends, but we've added a bit of content that applies to this module from another leading expert on the subject. Dr. Yalk is the Chief of System Research at the Mission Research Institute Mission Health System. He is also an adjunct professor in the Department of Emergency Medicine at the Medical University of South Carolina, as well as an adjunct professor at the Departments of Emergency Medicine and Neurology at the University of North Carolina, Chapel Hill. Dr. Yalk's experience with both neurologic emergencies and emergency medicine, along with his interest in and appreciation for EMS, has made him a bit of an expert in the development of stroke systems of care from the ground up. Most recently, Ed was the primary author of the 2021 Recommendations for Regional Stroke Destination Plans in Rural, Suburban, and Urban Communities from the Prehospital Stroke Systems of Care Consensus Conference. In a moment, you get to hear a few segments from the EMS On Air podcast, Season 2, Episode 33, which is also available for EMS credits. I think you'll find what he has to say adds value and nuance to what Dr. Brandler discussed in today's episode. Enjoy this additional segment. Dr. Yalk, Ed, can you let everybody know who you are, what you do, and where you do it?
Sure. I am an emergency medicine physician by training. I started practicing back when I finished medical school in my residency at the University of Cincinnati in 1993. And was very fortunate to get exposed to stroke at a very young age. Although I wasn't young, as part of my second career, I was still formative. And I met some great people in emergency medicine and neurology who convinced me that stroke was cool and this was a great place to spend my future. So I was at the University of Cincinnati on faculty for 10 years and then went to the Medical University of South Carolina for 10 years and was the division chief and interim chair there and helped start a statewide stroke program. And 3 years ago, I moved to the mountains of Western North Carolina to become the chief of system research for the Mission Health System. And I've been here for these past 3 years.
Well, it sounds like you got some expertise there, sir.
Well, I am a one-trick pony, and so this is all I do, so I better be good at it. I spend a lot of time with the American Heart Association on various projects involving stroke and also education, and then I work at the various state levels, directing either stroke oversight committees for like South Carolina, or I currently chair the EMS subcommittee on stroke here in the state of North Carolina. So this is, again, my passion and my gig.
I got you there. And you also have some direct contact with EMS out there. You're pretty active in the teaching world too, before pre-pandemic. You're not exactly just sitting there writing papers. You're also a hands-on kind of guy, right?
I try to Boston's EMS training program and work with them and did a lot of training in the pre-hospital settings for really at both at the state level, trying to create integrated training modules for them and also working with my more regional ones in stroke and also doing research in the pre-hospital setting as it relates to stroke.
I wanted to get your opinion on something and help us appreciate what is at stake for stroke patients.
Yeah, I think it can be boiled down to quality of life. We as emergency physicians, our goal is to have everybody survive to admission, and we rarely see what happens to these patients after they leave. And we've seen trauma patients die on our watch. We see STEMIs die on our watch. We really never see what happens to stroke patients, and they don't come in all bloody. They don't come in all screaming. They're very quiet. They sit there and they kind of get admitted in that same state. But once you start experiencing what happens to them, especially if they aren't reperfused, and the outcomes that they have and the quality of life that they no longer have, and not only the impact on that patient, but also their families and their communities, it really is devastating. And that's not something as an emergency physician I was aware of until I started getting deeper into the field. And so for me, what's at stake is being able to return a person to a good quality of life versus being dependent. And you've probably seen this. I know Steve has probably seen this. When I have gone to a patient's bedside when I'm on call for stroke, and I give them the options of what we might do for them, including TPA, and even after I tell them based on the original NIN study that there was a 6.4% hemorrhage rate, almost universally the patient or their family members, when it's a large stroke, will say, I know my fill in the blank would never want to live this way. So it's not the fear of death that really is terrifying to them. And there was actually a really cool study looking at, your aversion to an outcome. Death was an 8. And a severe cognitive, language, or even motor deficit, people don't want to live in that, quote, vegetative state. It's not a term I like to use, but this is what our people think of. And so they will take opportunities for an improvement in their current state, even if it comes with a risk of a worse state, because what they're currently in is really bad and it's not a tenable existence that they would want for their loved ones based on what they already know about their loved ones. So for me, what's at risk for not doing this right is leaving people in a quality of life state that was potentially preventable.
Help us really define, in your words, what a stroke systems of care is and how it relates to our stroke chain of survival.
So I'll start a little bit more broadly, and I'll just go with what is a system of care, because we didn't invent it for stroke. We've had it for trauma, and we've certainly had it for STEMI care. So a system of care is an organized, coordinated effort in a defined geographic area that delivers the full range of care to all patients. And it's integrated with the local public health system. And so when I say local public health, that can be at the state level, that can be at the county level, that can be within your regional group. It has to engage all the various stakeholders. And what we really want to ensure is just like what we want to do in the hospital, that this system operates cohesively, that there's a seamless transition from each phase of care. So from the 911 experience to EMS, to the hospital transition where they get brought to the emergency department, to the unit, the floor, the next place they go, or they go to another hospital. We want those transitions to occur as seamlessly as possible, as quickly as possible, and we want that team, that system of care that provided that smooth transition to have a process improvement element to this. And so we can go back and continuously improve and identify weaknesses in that system. Sometimes we can't fix it ourselves. Sometimes we have to go out and advocate for more resources. We have to advocate for money for our critical access hospitals. We have to advocate for more EMS. So a system of care, regardless of your disease state, an organized, coordinated effort around a time-dependent emergency that originates in the pre-hospital community, comes to the hospital, and then requires some form of definitive intervention to prevent the long-term morbidity and mortality associated with that disease. The other thing that I tell people, and when I made the decision to pursue medicine, an old physician once told me, son, there's 3 things you need to know about being a doctor. You need to be available, you need to be affable, and you need to be able. And since then, we've added affordability, and we've also added accountability. So as an individual and as a system, we have to be 24/7, right? This is not 9 to 5. It's not, well, I got a golf game, I can't do this or whatever. We need to be nice about it. We need to be supportive of people who are trying their best. And if it doesn't always go right, that's not their fault necessarily. This is an opportunity to learn. And hopefully we're going to be able. We all got to this point by having a certain degree of ability. And then when I say accountability, this gets back to the importance of feedback, typically positive and in a constructive way. Even if something didn't go right, there's still an opportunity to improve the system without alienating people and without causing the system to suffer from disengagement because we're saying you did something wrong. So I think when you look at an individual as part of the team and when you look at the team and system in its toto, availability, affability, ability, affordability, yes, that would be nice. And again, accountability.
Before I let you go, I want to talk about this really cool website you guys put together. When I say you guys, I mean the American Stroke Association. And if you go to stroke.org, www.stroke transport plans. This is a really cool website. So, Dr. Yalk, walk us through why it exists and what's there for our EMS systems looking for guidance on this topic.
I think, despite the white paper being, I think, a really nice document, no one's going to spend the time to read it. And again, you want to make it practical. You want the contents to be practical for people. And so, like a lot of things that are developed either from guidelines or from ACLS, we often translate it into something that is more visually appealing, and also we remember things when put into these structures. So this consensus paper and others that have come out recently were kind of distilled down into this website that provides a distilled version of some of the recommendations, some of the considerations, and shows how they can be put into a system of care, starting with 911 to where they need to finally go. That was the point of having these kind of infographics like so many people now use to convey important messages.
Well, thank you. We're going to put the link in the episode description. I really recommend that you look at this website. It's really cool. It's got some fantastic resources on it, especially if your agency or system is doing any stroke education or consideration of structuring its stroke systems of care. No matter what level, if you've been doing this for 5 years, 10 years, or you're just getting geared up for stroke in your system, this is a really cool website to kind of check out and understand where you're at with your conditions.
And Jeff, I'll add, when you see the infographics and you see the various recommendations for the geographic regions of rural, suburban, and urban, you'll see specific time measures in there, time metrics of bypass or triage or whatever. And again, getting to our previous point, these are not meant to be absolute etched in stone prescriptive numbers. These are meant to be starting points and references for the discussion, considering the unique resources that your particular stroke system of care and your particular region happen to have. So if your number doesn't look exactly like what the infographic looks like, it's probably because you fine-tuned it and you refined it to be more applicable to your particular region.
That's all for the show today, everyone. Thank you for listening, and thank you to Dr. Richards for coming on. I look forward to more episodes with you, and it's going to be a great time talking about maybe that mobile stroke unit and many other things that you're working on. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air, and please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.